everyone. Welcome back to Pain Points. I'm Dr. Jake Caylor, and today we're going to be talking about disc degeneration. Is it a cause or is it a symptom of dysfunction? I am a double board certified interventional pain physician out of Austin, Texas, and the goal of these sessions that we do every Thursday is it's really education. It's education and being able to advocate for both ourselves and our patients. So thanks for joining me on this journey as we continue on exploring different pain pathologies as well as ways that we treat them and the evidence for them. So thank you. As always, this is an interactive session. I have the comments up so I can follow along, and then we'll try to stay on a little bit longer this time because I know I missed a few comments last time. And as always, if you comment on it, I'll try to address that comment afterwards on Facebook or YouTube. Today, we're going to be talking about disc degeneration. We're going to be talking about what is the intervertebral disc. We talked a couple weeks ago about the vertebral body and its role. Today, we're going to be talking about what exactly is a disc. Consequences of disc degeneration. When you hear about degenerative disc disease, I oftentimes get patients that are extremely concerned about this. So we will be talking about that as well. And then we'll be talking about the degenerative cascade. What happens once someone has degenerative disc disease? Is this a one-way track or can you come back from this? And then, as always, we do our pain spotlight. And the spotlight for today is something called spondylolisthesis. And if you see that on your MRI, what does that mean? If you see that in your chart, what does that mean? And we'll be talking about interspinous spacers. Someone asked me to do a spotlight on the Minuteman procedure. So that's what we're doing this week. In the upcoming weeks, I think I'm going to do an entire session on interventional pain procedures such as spinal cord stimulation. How does it work? As well as pain pumps. How do they work? How do we manage them? And the evidence for those as well. So let's get started. The intervertebral disc sits between two vertebral bodies, and they're pads of this fibrocartilage material, and it provides cushion as well as support. And there's two main components to this. The center of it is called the nucleus pulposus, and the outer rim is actually called the annulus fibrosus. And both of these have an important role in terms of providing both shock absorbing capabilities of the spinal column in the front, as well as stability. Because if these were just cushions of jelly, then we know Jello would just shoot out and anytime we put any type of pressure on it. So there has to be both a compressive aspect as well as something to contain that. And that's really what the two functions of the nucleus pulposus and the annulus fibrosus are. The disc is going to contain water, it's going to contain collagen, elastic material, as well as inflammatory mediators. And that's one of the things that becomes so painful about disc tears. When you have an acute disc tear, this can cause pain that shoots down the leg, even if there isn't nerve pinching. And that's because just that inflammatory milieu, that mixture of pro-inflammatory cytokines, chemokines, all these fancy words for inflammatory stuff, that can spill on a nerve and really irritate it. And so this is really important to think about when we talk about disc pathology. The inside of the discs also get very little blood supply, and there's consequences to that. And one of the reasons delayed healing occurs. So here is the nucleus pulposus on this upper right image, and the annulus fibrosus on the outside. When we look at the intervertebral disc, as we age, we lose a lot of that cushion. And it's positively correlated with age, meaning that as we get older, we lose more disc, so it's a progressive thing. And there are genetic factors as well. Some people are prone to degenerative disc disease. I also see patients in their 90s and I look at them and I say, wow, you look like you have the spine of an 18-year-old. So it's important to understand that there are predicting factors for patients that can have degenerative disc pathology. Loss of water and cushion leads to disc height loss. And we know that the front of the spine holds up the weight of the spine. So losing height of the spine does have consequences. It's not just I'm getting shorter over time. There's other problems that are associated with that. That causes increased pressure in different aspects of the disc, and it also can cause some abnormal biomechanics. One of the things that happens is increased pressure on the disc also leads to less blood supply, because if the blood can't get there, there will be less of it. So that blood has to get there with pressure. There's also going to be decreased nutrients available for those discs. So you can see how this becomes a rapidly cyclical process where a little bit of disc disease leads to more disc disease through increased pressure and further loss of disc height, loss of nutrients, loss of water. It's thought of as progressive, but they actually can repair themselves as well. This is something that's been well documented in the literature. And that's why an MRI that shows the discs is one point in time. We need to look at the entire patient to be able to figure out where things are going. It's one point in time. The MRI is one point in time where you're laying on your back in a tube, not doing anything. And when we think about the disc, I like to think of a kind of a flat basketball. A basketball is not just like a blown up ball that you have on a playground. There's different aspects to it. Each of those parts does a different role. You have the bladder in the middle. You have this protective coating around the bladder that gives it support so it's not bulging in any one direction. And around that, you have the leather so that it maintains its shape and texture against different forces. But you can also see that having some type of problem with any one of these layers can lead to failure of the entire system. And that's how we really think about degenerative disc disease. Failure at one aspect can lead to incompetency in the rest of the disc and further progressive disc loss. When we think about the problems with degeneration, here on the right, we actually have the spinal column. The front is towards the left and the back of the patient is towards the right. In the front of the spine on the left, we have the big vertebral bodies, and in between that, we have the disc. In the middle, we have the spinal canal, and in the back, we have the spinous processes. The front of the spine, as we know from talking about this over and over again, holds up the weight of the spine, and we call this the anterior column. As you lose that height in front, it causes more stress actually on the middle column and on the back, because these are three columns that are standing up. If the front starts to lose height, it causes consequences on the back of the spine. So we have to think about this constantly. It can lead to pain and dysfunction, and that pain and dysfunction can come from the front of the spine. So it can be the discs, it can be the vertebral bodies. It can come from the middle of the spine. It can come from the spinal cord, pinched nerves. It can come from the back of the spine, arthritis in the facet joints, other problems with the interspinal ligaments. And then it can also cause problems and pain from the supporting muscles, tendons, and ligaments. So all these things can be consequences of the degeneration. And here we're actually going to see that in real time. We're going to see that as the disc actually starts to collapse down and push, it can cause problems both in the front and the back of the spine. You saw the spinal canal being pinched, and you see when the front of the spine goes down, it causes more pressure on the back of the spine as you lose disc height. So this is actually part of the degenerative cascade, and it's largely thought of as a progressive process. When the discs degenerate, they can lose height and function. It can be symmetric or it can be asymmetric. And on the right, we actually are using our grading scale for how we grade the discs. And you can see that with each one of these MRI pictures, you have two vertebral bodies that are sandwiching a disc that's in the middle. And as you go through the grade, you see that the whiteness in the disc goes away. Eventually, you are going to lose not only water in that disc, but you're going to lose disc height. And if it degenerates asymmetrically, that can lead to something called listhesis, which we're going to talk about later, or scoliosis, which is an asymmetric lateral shifting of the vertebral body. As we look on with further degeneration on the grading scale here, you can see that grade 8, that disc is almost completely gone. And at this point, the vertebral bodies have the ability just to fuse together. And that process is known as autofusion, and we do see that. When we think about the degenerative cascade, we need to think about the entire patient. We have to think about the front of the spine, and we also have to think about the back of the spine. When we get issues with the front of the spine degenerate, it causes excess stress on the back of the spine because this bone is one bone going front to back. When it degenerates forward and slips forward, we call that spondylolisthesis. And when it degenerates side to side, we call that scoliosis. And you can see here that as things degenerate and as it puts more pressure on the facet joints, you get things like bulging discs into the intervertebral foramen as well as the spinal canal. And then also we get arthritis from the facet joints that can push on that nerve. And oftentimes it's this that I'm showing to the patient saying, this is what's going on the MRI. So that was really degenerative disc disease in a nutshell. I'm not going to talk about all of the different neurosurgical or orthopedic surgical options for treatment of this, such as disc replacement, actually going and doing interbody fusions and opening these discs back up and recreating these spaces in the normal anatomy. That's something that we can talk about down the road if you'd like to. But degenerative disc disease is largely thought of as a progressive process. And today we're going to be, for our pathology spotlight, talking about spondylolisthesis. Now, a lot of you have come in and shown your MRI and said, it says I have spondylolisthesis, and that's what we're talking about today. What is spondylolisthesis? This big old weird word that someone had to pick that basically means you have a shifting of one vertebral body on another. As we've discussed, the shifting of the vertebral body is a problem, and that's because the bone, the spinal canal, runs in the middle of that bone. And so if you have two circles that normally are overlapping and you shift them, it creates a narrow space, and it can cause here, what we see on the right side, a spinal nerve kinking. And so spondylolisthesis, like I said, is the slipping of the vertebral bodies, and they can slip forward or they can slip backward, depending on the forces and the biomechanics. It also depends on the way the disc degenerates. In young people, generally, spondylolisthesis is caused by trauma or excessive bending, and you can actually have fractures that lead to vertebral body slipping. In older patients, it's generally thought of as part of a degenerative cascade, where you have loss of the disc, and then therefore the vertebral body slip. This leads to more pressure on the back of the spine. And here is an example of a patient that has a slipped disc. You might just look at this briefly on the x-ray on the left and say, okay, it looks pretty much in alignment, but you can see that the back aspect of this L5 is way far forward compared to the back aspect of this S1. And this is definitely something that would cause pain and possibly compromise of the spinal canal, because you have the spinal canal that would come down and then have to shift over to continue down this way. This is another test that we order all the time. It's called flexion and extension imaging. So if I send you for flexion and extension imaging, what I'm trying to figure out is, okay, I see that you have some slippage of the vertebral body, but is it moving even more when you bend forward or lean back? Or maybe when you bend forward, it's actually going back to normal, but when you lean back, like as you normally go about walking, it slips all over the place. This is an important thing to figure out. So this is a normal part of our workup for spondylolisthesis. Today we're going to be talking about the interspinous spacer as a possible treatment option for spinal stenosis and early grading of spondylolisthesis. In patients that have pinched nerves that are causing symptoms in the back and legs, an interspinous spacer can actually help pain and reduce the need for further surgery. Classically, that pain is going to be worse with standing and activity. It's going to be better with sitting down or walking with a shopping cart. That's leaning forward. And we call this the shopping cart sign. And that's because if you see this picture here, what you see is on the left would be a patient standing up, walking around. When you stand up, the first thing you do is your lumbar spine curves a little bit, and that can pinch down on the nerves a little bit more. But when you lean forward or you sit, that opens up the spinal canal, giving those nerves room to breathe. And this is essentially what an interspinous spacer does. And when you're walking with a shopping cart, you're leaning forward. That's opening up that spinal canal. So interspinous spacers are indicated for patients that have mild spondylolisthesis and mild to moderate stenosis, because a little bit of opening of that spinal canal can give you a lot of symptom relief. And you can see here with this patient, when you're leaning forward on a shopping cart, you're not doing a huge movement, but you are giving those nerves room to breathe. And this is the importance of having a team. A team is going to be the best in terms of figuring out, are you a candidate? Are you someone that's going to be a home run for this procedure? And so it's good to talk to your pain physician about this, but it's also important to optimize your care with a spine surgeon, with a primary care physician, and work together in a team model to be able to figure out, is this a right therapy for you, or is something else indicated? Because at the end of the day, we want good outcomes. That's the important thing for for our patients and these therapies to continue to be offered. Here's an example of a spinal canal that's pinched versus one that's open in cross section. And as I was saying before, the bone is one solid bone all the way around. So if you have two bones and they're misaligned, that means the spinal canal is going to be misaligned. But also there's other factors like the degenerative disc disease and the arthritis in the facet joints that can push on that spinal cord. And that's why a little bit of opening of that spinal canal can give you a lot of symptom relief. So when we talk about the interspinous spacer, it sits between the spinous process, and it's really holding the neuroforamen open. So it's going to take a spinal cord that looks like this on the left. And just by sitting here and opening up, keeping this space a little bit more open, it's going to create this picture. Now, this is obviously a drawing and a little bit exaggerated, but it can give you a lot of relief with a very limited amount of actual intervention. And there's multiple products that are on the market, and they each have evidence. A few of those products also fuse and stabilize the levels, and that can be very helpful for patients for the right indication. And they're all done through a very quick, minimally invasive procedure with a small incision that tends to be a few centimeters and allows you to place the device. There's a couple different approaches out there, and if this is a therapy that we've talked about or we're considering, then we'll talk about the different approaches for you and why one might be more advantageous than the other. There's a couple different products, but they all sit between the spinous processes and hold that space open. Some of them fix, some of them just prevent you from leaning back, but all of them are kind of accomplishing the same task, and that's keeping the spinal canal and the neural foramen open. Also, all of them have pretty cool marketing things and all these pretty little colors, but at the end of the day, they're all doing a simple functional job, and that's just holding that space open. But it's important to work together as a team to determine, one, is this the right therapy for you? And two, which is the correct product that would give you the result that you're looking for? So today, what someone asked me to highlight the Minuteman procedure. This is one example of how we do it. The Minuteman procedure is a minimally invasive procedure through a small incision, and it's actually done from the side. And there's actually a lot of benefit from coming from the side as opposed to going directly to the spinous process from the back. And so we're going to go through this video and show. So you have a patient laying on the stomach, and the first thing that you have to do is identify the target level in the spinous process. So what we do is we identify where that is. And once we identify that, we put a very small pin down to the target level, and we actually put it directly where we want it to go using an X-ray machine in a couple different views. From there, we put a few dilating tools down, and what that does is it doesn't actually cut any tissue, it actually pushes the tissue away. And this is really, really important because tissue that is just dilated heals much better than tissue that is cut directly. So we can use these dilating tools to open up the space that we need without causing any permanent damage. And that's the beauty of this approach from the side. Additionally, we'll take a tool once we have those dilating tools and actually measure the amount of space. Because we don't want to fix someone and open those spaces up too much, what we want to do is just make it perfect. It's what I call the Goldilocks theory. The Goldilocks theory is not too hot, not too cold, it's just right. And so that's the importance of identifying all of these things together. Once we have that correct size, then we can actually put the little spacer, the implant that fixates these two spinous processes down. And again, the whole procedure is about as complicated as what this video is showing, and it takes a similar amount of time, believe it or not. So once we have that dilator in position, then what we do is we put this small little thing that looks like a screw, and it's not a screw, but it actually is just going to go into place. And again, this isn't screw going into wood, it's really just helping it go through this ligament here. And you're going to deploy some wings, and that's going to actually pull back and hold those spinous processes open in that position that's going to give the patient relief. And the goal here is to prevent that patient from being able to collapse that disc space, holding it open just a little bit, just enough to get symptom relief, but also keep things from shifting around too much. And so this is the Minuteman procedure, which is one example of interspinous fixation. And what this does is allows the patient to get symptomatic relief, stabilizes the segment without having a large surgery. And properly chosen for the patient, this is a very great procedure. But again, the way I do this is I have all my patients work closely with myself, with my spine surgeons, to make sure that we're making the best decision together as a team, because we want the best outcome for the patient. And that's definitely the way that I'd recommend it be done. So that's degenerative disc disease. That is the Minuteman procedure in spinal fixation devices and interspinous spacers and spondylolisthesis. If you have any questions, I'm happy to take them now. We'll stay on just a little bit longer than we did last time because I know I missed some. And down the road, yes, I've heard you guys want to talk about spinal cord stimulation. I'm working on it. You want to talk about pain pumps? I'm working on it. Those are going to be awesome options for us to talk about, and I have a lot to talk about. The following week, I'm going to actually talk about neck pain because we haven't even gotten there. It's a totally different beast. And so, as always, join us every Thursday. Invite your friends, invite your family, watch us on YouTube or Facebook. Doesn't really matter to me. The goal here is, again, education, advocacy, and bringing us back together as a community. And so, I got a question here. Will the Minuteman put pressure on the front, and does it fuse? And the answer is, in short, is it's really not a matter of putting pressure on the front. It's more of relieving pressure from the back. As we talked about the front of the spine, so let's go back to this if we can. The front of the spine here, the vertebral bodies, actually bear the entire weight of the spine. So when you have degenerative disc disease, you actually have an atypical shifting of weight from the front of the spine onto the back of the spine. And that's something that causes that arthritis, and that's something that causes that posterior column degeneration. So it's really not as much about, are we shifting the weight onto the front of the spine? It's more, are we trying to restore the degenerative cascade back to a more normal anatomic alignment? And one of the things that I constantly talk about with my spine surgeons that's important is they say, well, Dr. Caylor or Jake, are you worried about putting the patient into more kyphosis or maybe overcorrecting? And that's the importance of working with the patient. I really want those vertebral bodies, if you look at the front of the spine, they're really nice and parallel to hold up the weight of the spine. And that's really what I'd like to see. I don't want to overcorrect. I don't want to undercorrect. I want to get just enough for the right patient to be able to open up that space and give the patient symptomatic relief. And the other question is, does it fuse? And the short answer is yes, it does fuse. And that's because there's a little bit of bony bridging that goes between it. And that's trying to give you an extra level of stability on that backside. Now, you can remember that when you have shifting of the vertebral bodies and when you have the degenerative disc disease, it causes more problems with the facet joints on the back. And that's these joints here. There's a lot more arthritis here. And when that arthritis occurs, let's go back even further. When that arthritis occurs, it can cause a lot of problems. And so the device itself is trying. So as that kind of shifts and creates problems with the back, what we're trying to do is actually stabilize the degeneration that's occurring in the back of the spine. And so it can be a very good option for adding another layer of stability. And this is that arthritis here. It's going to show you the pinched nerves from either the discs or the facet joints here. But the goal is to maybe offload these facet joints a little bit so they're not bearing that same amount of weight. So it's to stabilize the spine and give it an added level of security on the back. But it's not supposed to try to advance any degeneration that's in the front. And this is the importance of working closely, in my opinion, with my spine surgeons. Is a Minuteman good for a herniated disc? It's good for the right herniated discs. So there are a number of other procedures, and this is when we talk about the collaborative care model. My spine surgeons can go out and actually take a piece of that herniated disc and fix everything without having to do any other long-term procedure that leaves hardware in the body. So it's the right thing for the right patient. But I have definitely done this for herniated discs that haven't been amenable to other surgical options, or when the patient prefers a route like this. What's the difference between an interspinous spacer and the Minuteman spacer? Let's see. I have pain. I still have pain down the back and sides of my legs. Now, I can't comment on patient-specific cases, but one of the things that I have seen happen is when the devices are used and they become, or when the devices are used for patients that have too advanced stenosis as kind of a rescue maneuver, there is a possibility that you still have pain down the leg, or there's the possibility that the Minuteman devices, when they're going or when they're in, that you still have advanced degeneration that's continuing on or persisting beyond what the device was intended for. And this is the importance of working together as a team. I have definitely seen that. In my opinion, it's really important to follow the data. That's why I really want to find patients that have that mild to moderate and not severe or critical stenosis, or going outside the realm of what would potentially be a definitive surgical fix. All right, how many levels can you use this device? Generally 2 in a row or 2 next to each other would be the maximum number that I would consider. And again, it would be kind of in conjunction with my spine surgeons. And so I'm going to wrap it up after this, but as far as the devices go with the interspinous fixation, they can be extremely helpful for the right patient. As with any surgery, just like with spine surgery with rods and screws, or with intervertebral fixation done by a neurosurgeon or an orthopedic spine surgeon, this causes other stress at other levels. And so what we're trying to do here with these interspinous devices is, one, treat symptoms, so that's pain going down the leg. But what we're also trying to do is try to halt degeneration and see if we can stop that degenerative process in its tracks, or at least stabilize the back of the spine to give it a little bit more leeway in terms of what it can deal with. We're going to move on at this point and close it out for today. But as always, keep leaving your comments. If you guys want to continue to talk about interspinous spacers, please let me know. I will do an entire talk on interspinous spacers. I will go through the data. If you like that, please let me know. As always, thank you so much for joining me, and we will continue having these conversations every week. And I look forward to seeing you next time.